All right, I'm sitting here with Jared Powell, and we're talking rotator cuff tendons. I just recently did a show on them. I don't have too much interest, more like patellar and Achilles, but I think there's probably a lot of crossover between the tendons, and then probably a lot of maybe some differences too. So, anyways, tell everyone who you are.
Thanks, Jake. It's a pleasure to be here, mate. I've listened to a couple of your podcasts in preparation for this, and I think you do a really good job. So, I'm Jared Powell. I'm a physio from Australia. I have a PhD in the exercise-based management of rotator cuff tendinopathy. I wear a few different hats professionally. I still see patients. I have a telehealth business actually that I see patients from around the world with shoulder pain. I am a researcher, so I'm still engaged in a bunch of different research, looking at sort of how to best manage shoulder pain. And I teach other professionals, chiropractors, physios, osteos, SNC coaches, everyone who wants to have improved knowledge about shoulder pain. I have an online course and I do face-to-face teaching about shoulder pain, and so the shoulder's a real passion of mine. I've been into it now for 10, 15 years. The reason why I got into it is because I think it's a very poorly managed joint. I think we're still stuck in the dark ages when it comes to managing shoulder pain. And so my real passion is to sort of upgrade and improve the standard of care for shoulder pain.
Yeah, so mine is the thing I care is patellar mostly because I maybe had jumpers knee for like a decade. Did you deal with shoulder problems, or what's why this interest in the shoulder?
Yeah, I've had shoulder pain sporadically. I mean, I've trained my whole life in terms of weight training. I played like rugby over here in Australia when I was a kid, so you get injured. That didn't really inspire me to get into the shoulder. I got into the shoulder basically when I started physio. Graduated from physio school and started seeing patients, and I just figured out like what the fuck's going on here? Nothing's working, everything's working. There was no real rhyme or reason to it. I couldn't predict who was going to get better and who wasn't going to get better. There's a lot of cookie cutter algorithm based approaches to treating shoulder pain, which I just didn't like because I thought everyone's different. Why are we giving the same thing to everyone? So that felt it like a little bit uncomfortable to me. So I started reading more into it. And then I went overseas actually for a couple of years and lived in London. And I started working, or I sat in, I don't know if you know Alfredson, the Achilles tendon rehab guy, the eccentric protocol that was famous, or is still famous, but he invented loading basically 25 years ago for the Achilles. And I was lucky enough to work with him a little bit over in London, and that inspired a real interest in tendon management. And then gradually I started to, and that started out as lower limb tendons, obviously, because they're the sexier tendons, the Achilles and the patella. And then I gradually started to see more and more shoulder pain patients. So I started to think more about rotator cuff tendinopathy. And then that inspired me to get into a PhD. And that took me like 6, 7 years to complete because I had a family at the same time and got married and did all that crazy lifestyle stuff. And yeah, I've just finished it last year, and now I'm ready to conquer the world of shoulder pain.
So, how much of shoulder pain is rotator cuff tendon related?
Yeah, the stats are it's about 7 out of 10 is a rotator cuff related shoulder pain. So it's a good question. So like pain is complex, so it's really hard to know where pain is coming from. Like, can we identify a particular structure that is 100% responsible for somebody's pain? Probably not. It's always multifactorial and complex. But most of the data that we have in the literature seems to suggest that 70 to 80% of all shoulder pain presentations can be sort of housed under this umbrella term that we call rotator cuff related shoulder pain, which includes rotator cuff tendinopathy, partial thickness tears, full thickness tears, even subacromial bursitis, and all these types of pathologies. So we reckon about 80% of all shoulder pain presentations are due to these pathologies.
Hey, in our notes here, we talked a week ago. You talking about differential diagnosis, and I it's one thing repeated in the tendon world that like if you have a patellar tendon, it's going to be like you can point to it with one finger. It's not going to spread around. If you have the Achilles tendon, it's mid portion or it's insertional. When it comes to rotator cuff, I've heard that the pain can actually like spread down the arm or something. Or what's going on there?
Yeah, it can be quite diffuse, is what we call it, and vague. There's not really a pinpoint location of pain. Like it can be, the deltoid tuberosity is where most people will point to, or sort of the anterolateral region of the shoulder. That might be, if we were to look at all the different points that people would point to, there would be a big variance, but there might be an increased density around that anterolateral margin of the shoulder. So look, it definitely, that's something that you could look to in your physical examination, and when somebody's telling you their story, the location of pain can be sort of an indicator of rotator cuff tendinopathy. However, as you alluded to, it's not uncommon to be distributed down the arm, even to the elbow. Certainly down to the middle of the humerus, it can go. It can be this sort of dull, aching, throbbing kind of pain. But typically, it's a mechanical type pain that's worse when you try to lift your arm up in the air or under resistance into abduction or external rotation.
Yeah. So back when I always ask, I've been asking this to all these people I talk to with tendons, because I went through undergrad exercise science, master's exercise science, and I'm like, there was like nothing on tendons. There was no education on tendons. It's similar, maybe not as similar with like a lot of physical therapy or physio people I talk to. What for you with the rotator cuff? What was it like when you were getting your education, and how did you kind of develop this knowledge base? Was it just from working with people, or did you actually get a pretty good education in school?
Yeah, it's just same as you, really. It was a pretty, physio school is busy. You've got a few years to learn 1,000 different things. So everything's sort of, you introduce, but you don't go too deep. You got to get into that after your career. Sorry, after you finish with school and you're starting your career. So I came out of physio school in 2000, like the early 2010s, and the whole landscape was shifting at that time. So we were moving away from this shoulder impingement model, which maybe you want to talk about. That was, and that's sort of been a really interesting 10 or 15 years of moving away from shoulder impingement towards this more broader uh, condition that we call rotator cuff related shoulder pain, where compression of the tendon may be one element of what's causing somebody's rotator cuff tendinopathy or rotator cuff related shoulder pain, but it's not the only factor. So impingement's not the only reason that people get pain. And actually, there's been some really interesting studies done on surgery, so shoulder impingement surgery, where we've done sham surgeries on people with shoulder impingement, so fake surgeries on people with shoulder impingement, and those people get better equally as people who had a real authentic surgery for their shoulder impingement. So that was a real challenge. That was about 2018. That study came out, and that sort of changed the way we look at it. Because if people still have impingement theoretically with a fake surgery and they're getting better, what's the role of impingement in causing somebody's pain? So that was a real eye opener for a lot of people in our industry.
So what actually? Yeah, I want you to talk about that shoulder impingement model
Mm.
versus maybe what's it turned into. But what type of what was impinging? What did they think was impinging that was causing the pain?
So the supraspinatus tendon and the subacromial bursa is usually the most implicated structures that get impinged under the acromion. That was a theory that was proposed in the 1970s by an American orthopedic surgeon, Charles Neer, and he had a famous quote saying 95% of rotator cuff tears and pathology are due to impingement of the supraspinatus underneath the subacromial arch or the coracoacromial arch in the shoulder. And then everybody ran with that for like 50 years. Nobody challenged it, and we created a whole industry of how we manage rotator cuff impingement based on this imprecise theoretical rationale. Basically, like how he came up with the idea was basically just look at a bunch of cadavers, and then create a theory and then invent a solution to the problem, which was a surgery that he created, which was a subacromial decompression surgery. And then yeah, we did that for 50 years, and we started to challenge it a little bit more in the late 2000s, early 2010s, and we basically have no real evidence that it's a major factor that shoulder impingement is an issue that we need to dedicate much time to. It's more about improving the capacity of of the muscles and the tendons in the shoulder. We find rotator cuff tears in a lot of people without pain. We find rotator cuff tendinopathy in a lot of people without pain. We find subacromial bursitis in a lot of people without pain. All of these pathoanatomical findings that we call it are present in a bunch of asymptomatic people. So the relationship between pathoanatomy or pathological structures that we see on an ultrasound or an MRI, it's really quite an imprecise relationship between that and the experience of shoulder pain. So we're dealing with shoulder pain now in a much different way. We certainly consider pathoanatomy, we consider rotator cuff tears, we consider bursitis and all of these factors, but we also consider the whole spectrum of biopsychosocial factors which may be contributing to someone's pain.
So when it comes to all these things, like if we're talking like a rotator cuff partial tear or like I guess a full thickness tear, under imaging, how useful are these things for you, or does it just is it too broad to say? Is it individual?
Yeah, no. So I think that the data that we have is quite clear in saying that the information that we derive from an MRI or an ultrasound scan helps very little in how we manage somebody with rotator cuff related shoulder pain and even in their diagnosis. The best the most useful thing that we have with radiological imaging is to rule out like red flags or sinister pathology, like, a tumor in the shoulder or, profound glenohumeral osteoarthritis or maybe a frozen shoulder or maybe something like that. And then once we've ruled those factors out, imaging doesn't help us unless you have a very large, full thickness rotator cuff tear that needs a surgical procedure to heal the tear or to fix the tear. Outside of that, rotator cuff tendinopathy, a partial thickness tear, all of these findings that we find on an MRI really do not dictate or influence what we do to manage somebody with shoulder pain.
So I'm thinking of you earlier. You're talking about how these are kind of mismanaged. I'm thinking when someone has the shoulder pain, and they go in for medical care, what is the typical route that makes them mismanaged? Are they getting imaging immediately, and then are they going to
Yeah.
injections, or what's the typical route?
Yeah, exactly. So here in Australia, the typical route is GP and then imaging shows tear or may like usually a partial thickness tear or a full thickness tear of the rotator cuff. Certainly subacromial bursitis will be picked up a lot. As soon as subacromial bursitis is picked up, the radiologist will say on a report, this may be amenable to a subacromial corticosteroid injection into the bursa. The GP will see that. The GP will then refer for an injection. The person will get an injection. It will help for 2-3 weeks maximum. And that's what the data says as well. It helps in the short term, but it's no better than other therapies in the medium and long term. And there are toxic side effects of getting a corticosteroid injection as well, in terms of it really affects the tendon quality if you were to get multiple corticosteroid injections or even one into the shoulder. So patients are often going straight into that. They're bypassing any physiotherapy management or progressive and structured exercise to help their shoulder, which is probably the most evidence-based intervention that we have for managing people with all sorts of shoulder pain related pathologies. So yeah, it's this highly medical intervention and management where GP, referral for a scan, referral for an injection, maybe take non-steroidal anti-inflammatories or basic medication, and that's fine, but they're not really getting sort of best practice intervention, which is a shame, really.
Yeah, I'm not in like the physio or I guess in the medical field at all. I'm just a strength coach that helps people with their loading programs. But I'm thinking with like patellar and Achilles, it has to be more just from the outside. I'm thinking they go in. It seems like there's more of a conservative management. Let's send you to physical therapy. Let's try loading the patellar and loading the Achilles. At least that's how it seems like for me. Has that not taken hold in shoulder pain, rotator cuff pain?
Yeah, I think it's getting better. The Achilles and the patella have been revolutionized by this loading paradigm in the last 20 years, and I think we can thank Alfredson for that, and then Jill Cook and her team who have really carried the torch with that. And they've been shouting in a positive way at the medical community for a long time that tendinopathies of the lower limb need exercise and loading based management. You know, these tendons are mechanosensitive, they need mechanotransduction, they need loading, they need a stimulus. They don't need rest and they don't need medical management. I think a carryover into the shoulder has been our obsession with this impingement model, which is at its heart, it's a sort of medical surgical term. And so we haven't been as good as championing like non-surgical, non-interventional exercise-based management for these conditions. But that's changing. You know, the work over the last 10 to 15 years of myself and my PhD supervisors like Jeremy Lewis has really changed this whole paradigm. And it's starting to be loud and clear that even people with rotator cuff tears, they must or they should trial at least a 3-month period of a structured progressive exercise program with appropriate advice and education before they even consider having an injection, and certainly consider going down the operative path.
So when I look at the loading program for like an Achilles and patellar, it's always like starting with the end in mind, I guess. Like if it's a basketball player, we got to get you back to patellar tendon. We got to get you back to jumping and landing. But if you have patellar tendon and you're just like a power lifter, let's just get you back to squatting, I guess. When it goes to the loading program for these rotator cuff tendinopathies, is that something you keep in mind, or like is there kind of like a starting point? Is the starting point like isometrics? What type of thing? What type of things are you doing from a loading program?
That's a really big question, and that was pretty much the topic of my PhD, Jake, which took 7 years. So if you've got a spare minute to read 80,000 words, you're more than welcome to. It's so first of all, there's basically two separate approaches for managing somebody with a rotator cuff related shoulder pain. Now, that's a loading or strengthening pathway or a resistance training pathway. And then there's the other pathway, which is really popular, is a motor control pathway. And that's like trying to change how the scapula moves, or trying to change muscle timing and activity of the trapezius, or the muscles of the serratus anterior and things like that. Basically trying to optimize or improve how the shoulder moves. And these two different approaches they couldn't be more different in their rationale and their mechanisms of how they may work. But when we subject these two different approaches to a clinical trial and compare them, they actually produce comparable and equivalent outcomes in terms of pain and function. So that's a bit of a weird thing with the shoulder. There's two different schools of thought that dominate the literature, and they both produce identical outcomes in terms of pain and function. So that makes me think, what's in common between these two programs that's helping everybody, or helping a lot of people with pain and function. And maybe that's a different conversation that we can have. But my priority is to go down this resistance training pathway, which you would be familiar with the Achilles and the patella. Do you start with isometrics? That's a fabulous question. I know it's very common to do that in the lower limb. We don't have a ton of good data that suggests we should do that for the rotator cuff. I think it's a nice starting point if someone has a highly irritable pain presentation of their shoulder. Now, how do you do it? Do you do the Rio long hold? Do you do the Aaron Patsis short, highly intense holds? I think it just depends on the patient. We have no data to suggest that, like we do in the lower limb, the Aaron Patsis protocol is great for improving mechanical properties of the Achilles, like increasing tendon stiffness. That work has not been done in the rotator cuff, so it's entirely speculative. I think it's an interesting path to pursue. I know that Keith Barr is doing a lot of good work as well with isometrics, longer hold isometrics for sort of changing the tendon structure. Again, not being done in the shoulder. So highly speculative. And this is why I'm pissed off at the shoulder world, because we're lagging behind by like 20 years, mate. It's really frustrating. So I tend to start by like putting the individual in the center. I like you, I reverse engineer. What do they want to get back to? Are they a 70-year-old person that wants to be out of pain? That approach will be entirely different to a 30-year-old person who wants to get back to baseball or playing football or tennis. They're going to need, in my opinion, a far different end point of the protocol. So the starting point might be similar. It might just be basic movement, basic loading through the shoulder. And at the end, I will progress to higher load and then certainly plyometric based activity activity to try and condition the muscles and the tendons of the shoulder to be able to tolerate that load that's going to be required once they get back. So the starting point of a program may be an isometric, it may be a low-grade isotonic movement. It will probably involve some external rotation movements to sort of localize the rotator cuff tendons, but it will involve a lot of pushing, it will involve a lot of pulling, it will involve a lot of raising overheads, because all of these, let's not forget that the shoulder is far more complex than the Achilles or the ankle joint or the knee joint, which are hinge joints. The shoulder is a ball and socket joint that has a high degree of mobility and range of motion, and it moves in a bunch of different directions. So there's a bunch of different ways to load the rotator cuff. You can load it into pushing, you can load it into pulling, you can load it into rotation, you can load it into elevation, you can load it into reaching overhead. So the exercise I prescribe will be highly context specific and based on the individual into irritability of the patient and their goals, preferences, wants, and needs.
Yeah, so we were talking about the differences, and you're talking about these rotator cuff tendons being positional tendons because they have this distinction of a positional tendon versus an energy storage tendon, and the energy storage is usually the Achilles and the patellar tendon. They have their big tendons, they strain a lot, they deal with a lot of stress, and then the positional are kind of just there to transfer what the muscle's doing to the bone. Um, and when it comes to the rotator cuff, you kind of put them in this positional camp. These smaller tendons that are positional, they don't deal with too much stress. So I'm thinking of the rehab. I'm like, with the Achilles, you need like a huge contraction of the calf to even get that tendon to strain. With the patellar tendon, you need a huge contraction of the quadriceps to get the tendon to strain. When it comes to rotator cuff, is it kind of like you get a strain or you get you get a pull on the tendons from basically anything you're doing shoulder wise?
Yeah, that would be my guess. We don't really know again because it's under investigated. So, the rotator cuff tendons are a positional tendon. They're fundamentally different in function to an energy storage tendon like the Achilles and the patella. They strain a lot less. They strain maximum like 3 to 5% versus the Achilles and the patella, which can strain 3 times more than that. As you said, their main function is to transfer force basically from the cuff muscles to the bone to position the hand and the arm in space. So, so yeah, do we need to place a profound load on the rotator cuff tendons to produce a strain to manufacture a change in the mechanical properties of the rotator cuff tendons to produce some sort of an outcome? I don't know, but I'm I'm cautiously like skeptical that I don't think we need to, because I just don't think that that's how the rotator cuff tendons function. I think it's alluring and appealing to think like that because that's how the Achilles and the patella works. But I just don't know the actual role of 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 generating a stiffness response in the rotator cuff tendons to produce an outcome for performance or for pain. Because if you would imagine somebody has a small full thickness tear or a partial thickness tear of the rotator cuff, which is different. The Achilles and the patella don't tear much. They obviously do. You can, but it is really common to get these little tears, what we call like holes in the blanket. You get these little like focal tears in the rotator cuff, which means the rotator cuff can still function really well, but there are these tears in the tendon which will affect its stiffness qualities. So can we really change that with a progressive loading protocol? I don't know. The jury's still out. I'm just a little bit I'm a bit skeptical in just translating what we have from the Achilles to the rotator cuff tendons.
Okay, kind of a sidetrack because I was going to go on with stiffness and the strain and everything, but you talked about these holes in the blanket, and I've always that Keith Barr stuff with the hole in the tendon trying to fill it in, and then I think it was Jill Cook saying like this is mechanically silent. You're never gonna turn these back. Let's just the tendon's gonna get bigger and let's work on the healthy section. So it's like a donut hole analogy. And I've always tried to play both sides of the fence, and I found a few anecdotes of tendons with holes filling in like Seth O'Neill, some horse tendons where that happens. When you see these holes in the blanket of the rotator cuff, do they fill in naturally over time? Can they fill in naturally over time? It may not matter, like you said, with the partial rotator cuff tears and the pain, people can get back just fine. But yeah, do these fill in? over time?
On the whole, no. Rotator cuff tears don't really heal. There is isolated evidence of healing in 1 to 2% of cases. But if you were to find a rotator cuff tear on 100 people, 50 of those will have a progression of their rotator cuff tear over the next 5 years. Progression meaning it will get bigger in size. Now, I don't. It sort of varies on how much bigger it gets. Over time, it will depend on the quality of your rotator cuff tendon tissue, and that depends on the quality of the health of you as a human being and also your age. But typically, the natural history, and when I say natural history, the trajectory of a rotator cuff tear over time will be to enlarge generally slowly. So smaller tears enlarge slowly over time, larger tears get bigger quickly over time. So if you would have a partial thickness tear, maybe 20 to 30% of people will have a bigger tear if you were to check back on them in 5 years. If you were to have a full thickness tear, maybe 50% or more will have an enlargement of that tear over time. It's rare to get a healing or a filling in of that tear over time, which is, might be depressing for some people, but it doesn't really matter because the rotator cuff can still function very well from a strength and function perspective, even in the presence of these tears. The rotator cuff is actually engineered in an ingenious way. Um, and I don't know if you want to get into this, Jake, but I will. There's something called the rotator cable in the rotator cuff tendon complex, which shields the areas where we get a lot of tears called the rotator crescent. So this rotator cable distributes force around the tears in the rotator cuff tendon complex so that individuals with a rotator cuff tear will not know they have a tear because they have full function. These tears are completely silent, which is what Jill refers to them as. So there is no way of knowing, apart from getting a scan on these individuals, that they have any pathology of their rotator cuff, because evolution has done a wonderful thing for us in our shoulder and has created this cable which can disperse force around the tear so that that person can function beautifully. And I'm not just talking they can lift their arm up. We have baseball players, we have Olympic swimmers, we have high level athletes with these pathologies that are functioning at the top 0.1% of humanity, and they've got no issues. So I think that's really cool.
I'm wondering if there is a distinction here, because when we look at patellar and Achilles, it's like we can get the tendinopathy where it's like you just at the, well, I guess you get mid portion insertional with the Achilles, and then usually at the proximal. Well, with the patellar, it can be the quad at the top of the patella, the bottom of the patella, or the tibial tuberosity. It's like you just have this maybe like this inflammatory thing going on in the tendon, or this like degeneration tendinosis thing going on in the tendon. But do you not get that with rotator cuff? Is the rotator cuff just gonna get these partial tears? Is there not like a, you know what I'm saying? Because like, yeah, I don't know if that's a good question.
Yeah, are you saying like a tendinopathic response as we see
Yeah,
in the Achilles
is
and the
there,
patella?
because you're talking so much about these partial tears and full thickness tears, and it's like so common in the rotator cuff versus the patellar and Achilles. It's not very common because those people will probably have some significant pain and disability if they have a pretty significant tear of that tissue. It's so common for them to just have a tendinopathy. But in the rotator cuff, all of this disability, it sounds like a lot of it's coming from these type of tears. So is that a distinction with this tendon versus these big energy storage tendons?
Yeah,
Or not?
it's more of, so rotator cuff pathology is typically a longer, slower brewing, like cascade of degenerative pathology that will brew and take time. You can certainly get, the classic Jill Cook reactive tendinopathy of a rotator cuff. I surf, and so I don't surf much now because I have kids, and so when the surf's good, I'll surf for 3 hours and I'll get a raging supraspinatus tendinopathy typically because I'm just subjecting that tendon to a massive amount of load that it's not ready for. So that still happens. That definitely happens more in probably a younger cohort that does a little bit too much too soon. So you'll get a highly disabling, painful response. But that typically that is pretty good at self-resolving with load management or just doing some basic exercise or taking some anti-inflams to help that in the short term. But typically the continuum of issues that we get in the older population, which isn't, the sexiest population to consider, but the most common presentation of a rotator cuff pathology will be in their 50s and 60s with a degenerative rotator cuff that probably started as a slow brew tendinopathy that progressed to a partial tear that may now have a partial tear, full thickness tear, which is causing them some grief. So that's typically the presentation that we get. But if you were to go and be a swimmer for the Australian Olympic team, a physio for the Australian Olympic team or the US Olympic team or whatever, these people will get these highly reactive tendinopathies of the shoulder. And actually, the swimmers are a really interesting population to look at because they're like the runner population of the Achilles tendon. So what some people have done here in Australia, they've looked at swimmers before a session in terms of their rotator cuff tendon thickness and cross-sectional area, and then they've looked at them after a session. And the rotator cuff tendons, particularly the supraspinatus and the subscapularis, are swelling by 5% over a session, one session. At the end of a week, these tendons are swelling by 10%. So at the end of a full training week. So there is this normal loading response in the rotator cuff tendons that we're seeing in the Achilles as well. And so they're responding to load normally. The question then, Jake, becomes like, what's the tipping point? When does this normal adaptive response in loading that causes thickening, when does it tip over to developing pain? And so that's the crucial question that we need to ask, because swimmers train Monday to Saturday, they take Sunday off. Is that rest on Sunday enough to reduce that tendon thickness and cross-sectional area down to resting levels? Or, is it slightly becoming thicker and thicker week on week throughout their training career until it eventually results in pain? Because I think the stats are in swimmers that like 90% will develop a shoulder pain situation across their career. So it's highly prevalent.
Mm-hmm. Yeah. This idea on this tipping point to pain. When we had our conversation a week ago, you were talking about age being the biggest risk factor or for this rotator cuff tendinopathy, and then I just look at the patellar and it's like, well, if you're not jumping, you're not doing explosive sports, you're probably not getting the jumper's knee. Versus Achilles can kind of happen over a lifetime. Probably more likely if you use it a lot with distance running or something like that. This tipping point to pain though, so I'm thinking of this age, she's just getting older. I'm thinking the big energy storage tendons are like, you're more likely to get them if you're using them a lot. Maybe you're using the rotator cuff your whole life, but it's like, I think you get a lot of people that are kind of sedentary and not using them a lot, go over the tipping point and get pain. So why is it these older people are getting it? I'm thinking, because I've talked recently to guys with metabolic tendon issues, is that a big thing that is causing some of these later in life rotator cuff tendinopathies? Or what do you think?
Yeah, good question. The biggest risk factor for developing rotator cuff pathology is simply age. And there's a famous American orthopedic surgeon, John Kuhn, who's been on my podcast. Shout out my podcast. Go listen to him talk. And he says a rotator cuff tear is just a function of aging often. So it's like getting wrinkles on your face or your hair falling out. I'm bald, so that doesn't hurt me, but it's happened with age, right? And it's the same sort of thing that we see with the rotator cuff tendons. So that is the number one risk factor. Why? Just that tissue seems to demineralize and denaturize over time. The rotator cuff tendons have a pretty poor vascular blood supply, and they just seem to degenerate over time. And it seems to be worse if you use your tendons more. And so there is an association between your dominant arm developing a rotator cuff tear versus your non-dominant arm. You mentioned metabolic factors. That's a really good question. Yes, metabolic factors are associated with rotator cuff tears. Diabetes, metabolic syndrome, smoking, alcohol consumption, all of these things which affect our metabolic health are associated with a rotator cuff tear as well, because it affects our blood flow and our healing response. If you do any of these things, anything's going to take longer to heal. Even a skin lesion will take longer to heal. Same things that we see in our tendons as well.
So I've looked. I had a while where I just want to learn about tendons, so I bought all these tendon textbooks, like maybe 20 or 30, and they were just miserable to read. But the rotator cuff, they kind of talked about some of these like tendon transfer surgeries. So when you have these really big full thickness tears that like maybe you can't do anything conservative management, what are people doing? Like, what have you seen people get these tendon transfers to like whatever fill in this hole in the blanket or whatever the analogies you want to use? And how do people do they rehab just fine after this, or yeah, I don't know if you have any insight there.
Yeah, yeah, not they don't do that good, to be fair. The massive rotator cuff tears. So massive is a literal term. It's a term that we use in the literature. A massive rotator cuff tear means a tear that's bigger than 5 centimeters, which is pretty big. When you put 5 centimeters into your shoulder, it's a massive tear. So nothing that we really do for these people is hugely effective. In fact, if you were to compare a surgery for a massive rotator cuff tear to an exercise program for somebody with a massive rotator cuff tear, they get better at the same rate. So exercise is not ineffective for these people, and surgery isn't the answer, no matter how big the tear is. Maybe, except if you are a younger person with a larger tear and you've got good tendon quality, a surgery may be something that you should consider, because that tear is just going to get bigger and bigger over time. So yeah, I'm not a huge proponent of surgery, even for massive tears, because I see some really bad outcomes. And here's a stat, Jake: the bigger the tear, the more likely your rotator cuff repair surgery is to fail. So there's some data that's come out that suggests that if you're a 50, 60-year-old person and you have a large full thickness rotator cuff tear, there's like a 30 to 40% chance that tear is actually going to heal with surgery. It's going to re-tear within the first year. So then what's the point of the bloody surgery if the thing's re-tearing in 6 months? I would just avoid it if it's going to re-tear.
Yeah, yeah. Kind of to go back, you were talking about this whole cable thing, the rotator cuff cable, whatever that term was you had, and you're talking about the filling the holes in the blanket. And I'm going back to my patellar tendon in the first place. I did conservative management, wasn't getting better. They did an MRI, and they said partial tear of the tendon. Which now it's like you hear people say with patellar Achilles, they can't determine whether it's a partial tear or just like degeneration. So it's like if they give me the idea that I have a partial tear, I'm gonna think this thing isn't gonna heal and I need surgery. And that's what I thought, and that's probably went into my conservative management not working, although the conservative management did suck. But yeah, I'm wondering with you get these people come in and they know they have a partial tear in their rotator cuff, and that's probably a scary thing for them. How are you explaining this? I think I forget who it was. I don't know his name. He was talking about like the rotator cuff like a sock. And like you can get a hole in the sock, but the sock still works fine. Are you using analogies? Are you using this rotator cuff cable idea for them? Because like nobody wants to hear that they have a partial tear in their tendon.
Yeah. Yeah, it's a huge problem, Jake, and especially if they go get this scan and they don't have the findings contextualized or explained to them. And this is why I hate people just going down GP orthopedic surgeon pathway, because GPs, orthopedic surgeons, I love them, but they're not really good at explaining that a lot of these things exist in normal people, because that's not really their job. Well, it should be, but they haven't been trained that way. So people come to us and they have partial tear, full thickness tear, and they're obsessed with this tear. They're fixating on the tear. And we have qualitative studies, which means qualitative means we go out and interview people with a full thickness or partial thickness tear. And we ask them, what does this mean to you? And they're like, it's a tear. It needs to be surgically fixed. What's physio going to do for me with a torn tendon? So straight away, there's a huge barrier between their expectation of recovery and what I'm offering them. And typically they think that a tear is going to get worse with exercise. Why would I lift a weight up if I've got a tear? That tear is going to get bigger and my pain's going to get worse. And so it's a whole conversation that we have to have before we proceed with rehab, because these barriers are actually a problem down the line. So if somebody has a poor expectation of physiotherapy, that will mean they will have a worse outcome. And we actually have evidence that suggests that. So if somebody has a low expectation of recovery with physiotherapy, often because they think they have a tear and that it needs surgery, they will have a worse outcome versus somebody who has a high expectation of recovery. So it's incumbent upon the healthcare worker, that might be you as a strength coach or me as a physio or whatever, to counsel these individuals that, yes, you have a tear. That is extraordinarily common. In fact, if I was to take an image of your opposite shoulder, there is a better than 90% chance you're going to have exactly the same pathology on the other side that's not causing you any pain. So that sort of starts a conversation between, oh, okay, that's interesting. So they say, okay, well, what do I need to do? Well, that's a long conversation again, but let's just start with some exercise. How this exercise is going to work is not going to heal your tendon, but it's going to make you more confident to move. It may help with some tissue turnover within the tendon, make the tendon tissue that's still there, that's still healthy, a bit stronger. It may increase your muscle strength. It might decrease your fear of movement. In the shoulder, we see a lot of kinesiophobia and fear of movement, which is a real barrier. You do see it in the lower limb tendons as well, but we see it in a higher prevalence in the upper limb tendons. And so exercise and having this conversation about what exercise might do via the full biopsychosocial spectrum is super important, Jake. Like if you're not educating people about, the prevalence of these findings of tears, of rotator cuff tendinopathy, then I think you're setting yourself up for failure, because even if the person doesn't appear worried, that humans are simple creatures and we think linearly. We think cause effect. So we think cause of my pain is rotator cuff tear, effect and solution of my pain is to surgically repair that tear, and then everything will be hunky-dory or back to better or back to normal. And that just ain't the case, and it's our job to educate before we just jump in. Okay, here's your 12-week loading program, and you don't consider any of their thoughts, feelings, and beliefs.
Yeah. I'm curious how you deal with this, because when someone comes to me patellar tendon, and they've had it chronically, I like to have something just like a no-brainer where I'm like, if they do a leg extension on both legs, their healthy side, maybe they do like 50 kilos or something, and the unhealthy side they do like 5 kilos, and I'm like, okay, your quad, and they can look at their quad, and their quad is smaller, and I mean, it's weaker because of that. So I'm like, let's go after the quad, the thing that's attached to the patellar tendon. And if we get that quad back up to par, the patellar tendon is probably going to feel better over time, where it's more protective. Do you have anything in the shoulder like that you can go to? Like, do they get muscle wasting? Do they get this extreme weakness? Is there something you can be like, this is a no-brainer. Let's bring this up, and maybe your symptoms will improve. Is there anything that you have that you can go to like that?
Yeah, so people with a rotator cuff, a symptomatic rotator cuff tear or rotator cuff related shoulder pain, as we call it, are weaker when we do force testing on them. And a really easy way to get them to buy in is you get them inside lying and you do an external rotation to fatigue exercise where they get a 2 or 3 kilogram dumbbell, they lie on their side and they do an external rotation to fatigue. They're always going to be weaker or do less reps on their affected side versus the unaffected side. So, and it usually won't hurt them because it's a very low intensity exercise, more of an endurance based exercise. And so they see that they're weaker, and then bang, there's some buy-in to starting some exercise. There's also another thing that you can do is what we call a symptom modification, not procedure, but you identify their painful movement. Now that's usually abduction at about sort of 70 to 90 degrees in the air. And they've usually got some sort of a fear of that movement as well. And so you modify that movement subtly. So that might just be bringing that movement 20 degrees more forward into the scaption plane. And then all of a sudden that person's pain at that range of motion decreases by 30, 40, 50%. Sometimes it goes away completely. And so then you say, well, look at that. All you've done is you've changed your position of your arm by 30 degrees. You're still at 90 degrees elevation, but you've changed it into the more sagittal plane, and your pain has reduced significantly, but you're still moving it, you're still loading it, you're still exercising it. That's awesome. How good is that? You don't have to be afraid of lifting your arm up. It just means that a certain position is a bit sensitive at the moment, so we can avoid that position for a temporary amount of time. We'll eventually expose you to that movement eventually, but let's just focus on the things we can do until we can build you up to those positions eventually.
So there's this idea with, and you kind of talked about it with this. Maybe it was that impingement thing. I'm wondering if that impingement and this compression idea are the same, but you get it with like the insertional Achilles, deep dorsiflexion can cause compression, cause pain, so maybe avoid that for a while. Quad tendon, deep knee flexion, patellar tendon, maybe also deep knee flexion, can cause compression symptoms, and it's like maybe we just avoid it, let it settle, and then get back to it. What's going on with the rotator cuff tendons? Are they getting compression? Is this something that where you do the same thing where it's like let's just avoid it for a bit and get loading in and then kind of introduce it as things settle? Yeah, what are you doing?
Yeah, so it's a good question again. You're coming up with all the good ones, Jake. So tendons compress no matter where you are, right? No, every single tendon will compress. And if your tendon is sensitive, it will be provocative. That will hurt if you compress it. So, but we just have to be careful in saying that that compression is the primary contributing factor to your shoulder pain, and we need to avoid those compressive positions forever. I listened to Pete Maliaras talk about this in the Achilles. You can temporarily remove yourself from that painful position, but you have to expose yourself to those positions at some point in the future, especially if you're a younger person who wants to use your arms overhead. If you want to get back to doing shoulder press, you have to get into that impinging position. Like 50% of people or more will have rotator cuff impingement in their shoulder when they lift their arm up, and that's often not painful. 100% of people, when they lift their arm fully up overhead, will have not a subacromial impingement where the tendon is being compressed under the acromion, but what we call an internal impingement where the supraspinatus is getting pinched, let's say, between the top of the glenoid labrum. So if you were to lift your arm overhead, you're getting compression between your supraspinatus and the superior portion of your glenoid labrum, what we call internal impingement. That happens in 100% of people when you lift your arm up overhead. So it's not pathological, that's physiological, that's normal, that's what happens. If you sit down, 100% of people are going to have compression on their ischial tuberosity and their proximal hamstring tendon, right? But it doesn't hurt unless you have a proximal hamstring tendinopathy. It's sensitive. So you just have to contextualize all these things, because then people will say, it's impinging, it's hurting, I need to remove that impingement. Now, typically that comes down to a surgical fixation of the acromion, try and chop it off, and that's meant to help their pain. And it doesn't, as I suggested a moment ago, it's no better than a fake surgery. So you just need to have these conversations about, yes, compression may be provocative for you now. Let's take out that load temporarily, but you will have to reintegrate it into your life at some point. So you're just, and that for me, you don't even need to talk about compression. You just talk about it's a sensitive position, it's a sensitive movement. Let's get out of that sensitive position before we eventually reintegrate it when it's not so sensitive.
Yeah, this feeds into my next with the pain during rehab, and kind of with the patellar tendon, I'm like, or maybe with Achilles, I'm like discomfort in training is probably okay, but it's like you that 24 hour or the next day pain response. If you're waking up and the thing is really sensitive for the next day, I'm like that probably means it's kind of like a maybe a an adverse response and you did something maybe it was too much or a bad position or something. What are you looking like with pain during rotator cuff rehab? And then is it pain during? Is it pain the next day? What are you trying to listen to? And are you listening to it like yeah, how much are you listening to it? When are you listening to it?
Yeah, so it's usually pain that evening and the next day that we're worried about. There's been a real change in pain during exercise. So we're sort of catching up to the Achilles and the lower limb here, where we're permitting like up to 5 out of 10 pain in people exercising with a rotator cuff related shoulder pain, as long as that pain is very quick to settle afterwards and is certainly no worse the next morning, that 24-hour response as you alluded to. So we've got a review at the moment that's under review at a journal that compares pain during exercise, like allowing pain during exercise versus avoiding pain during exercise for a bunch of different conditions. And we're finding there's no difference between allowing pain and avoiding pain. So if somebody is amenable to tolerating a moderate amount of pain during their exercise, you can let them, that you don't have to avoid pain during your rehab. So I think that's a really liberating thing. At the same time, if somebody's petrified and terrified and scared of pain during exercise, you don't have to force them into it, because they can still have a pretty good outcome with avoiding or temporarily removing that pain as well.
When it comes to their life outside of the rehab, I'm thinking of like the lateral hip with females. You know, if they're like, I guess if they're like hanging out on the hip, or if they sleep in a certain way, it can really maybe cause this compression or something, and keep the symptoms going. So it's like they have lifestyle fixes to try to avoid this. What do you? Is there anything with the rotator cuff of like maybe sleeping positions, or positions they have to do for their work? Yeah, is there anything your advice you're giving on maybe avoiding certain positions so that the tendon can settle?
Yeah, like sleeping is usually a common issue for people with like a unilateral rotator cuff pain. So sleeping on the affected side can be painful, usually in the short term when there's like an inflammatory process going on. Yeah, simple. Just go to the other side, maybe put a pillow underneath that arm. That can usually help, because when you're down in a fully adducted position, that can be a little bit provocative as well. So getting them up into a little bit of abduction with a pillow under their arm can help too. But apart from that, it's usually the positions are higher up in range of motion. So it's really hard if you're a hairdresser and you're sort of up at 90 degrees cutting hair all day. If you're a carpenter, or what we call a chippy here in Australia, and you're hammering overhead, that's tough. Like, you're going to have to get good at using the other side, or you're going to have to modify it somehow by going up on a ladder or up on a step, so you've got your arms slightly below that, 70 to 90 degrees, which is typically where you feel that pain. So it really comes down to the irritable movement of the individual, and it can change. Some people have pain into external rotation, some people have pain into elevation, some people just have throbbing pain at nighttime, which is different. So just find the person's painful movement, suggest tips for modifying it, and that's usually really helpful.
Hmm. Yeah. Um, um, one thing we had talked about a few days ago was the all the adjuncts. So you got shockwave, you got PRP, you got corticosteroids. Where do you stand with all these things?
Yeah, shockwave doesn't work for rotator cuff related shoulder pain, maybe unless you've got a calcification, so a calcific tendinopathy of the rotator cuff might be a bit more evidence. Not for me. PRP is no better than an exercise program for rotator cuff related shoulder pain. So, I mean, you can do it if you want, but it's just no better than doing a 3 month exercise program. So if you want to spend $600, $800, go for it. But that's not what I would recommend. Corticosteroid injections are a tricky one, because in the short term, they are associated with a really profound reduction in pain. They can really help people. But after 6 weeks, typically 6 to 8 weeks, they're no better than if you didn't have the injection. And then down the line, they typically get worse compared to if you didn't have an injection in the short term. Now, what this means is often that people go and get an injection every 6 to 12 weeks because they have that short-term effect, and they want to keep getting that short-term effect, and it's diminishing returns. That effect gets less and less and less over time, and they're throwing all this catabolic, toxic stuff into the shoulder as well, which has been associated with increased rotator cuff tear rupture down the line. So, like, I'm fully sympathetic to people with severe shoulder pain and wanting to get an injection to help them in the short term. They're totally okay to do that. My job is to counsel them on the pros and cons of doing that, and what would happen if they didn't get the injection. And then typically, it's a pretty good outcome if they don't get the injection. The biggest meta-analysis and systematic review that we have, Jake, on this is that um, that short term, there's an effect of corticosteroid injections. After 6 weeks, there's no effect. Longer term, it's a worse effect. And we've sort of quantified this in what we call a number needed to treat. So we would have to inject 5 people with a corticosteroid injection for a symptomatic rotator cuff tendinopathy for one person to experience any benefit that is better than a placebo injection. So you can equate that to only 20% of people will have a benefit that's better than a placebo, and that benefit is lost at 6 weeks. So those numbers when I translate those, heavily mathematical numbers to a patient, they say, oh, there's a 1 in 5 chance this is going to help me, and that benefit's going to be gone by 6 weeks. Then I probably won't proceed down that pathway. But it's not my job to sell them on it either. Like, I try to present the data in an unbiased way, which is challenging for me because I like exercise-based rehab. But I try and present the data in an unbiased manner. This is the literal cold hard numbers on your chances of success here. You go and do with that what you want. If you want me to give you an exercise program, beautiful. Let's remain doing this. Otherwise, come and see me after you've had an injection and we'll have a conversation then.
Yeah. I a couple more questions if you got time. You good? Okay. The so I want to go on stiffness, but maybe I'll go on this one first. Is I'm always trying to like I guess everyone's still trying to understand what is going on in tendon pain. And I know you had Neil Millar on maybe a few years ago, and there was this whole push of like at first it was tendonitis, and then everyone's like, no, there's no inflammation. It's tendinopathy because we don't. And then there's kind of this. He was kind of presenting that there is inflammation. There's immune cells that have these chemicals, and Stephanie Dakin kind of same thing. So I'm like maybe there's all of this stuff going on at once: the degeneration, the immune response, the inflammation. But I'm still thinking like when I get someone with a bad patellar tendon and I rehab them to get better, it's almost like at this point I don't really care about the tendon too much. I'm like, let's work on the quad muscle, all the muscles around. Let's work on the kinetic chain. Let's try to maybe give the tendon time to settle from the provocative activity and then gradually introduce it back. But I'm still like, I don't know what went on to take away the tendon pain. And you're dealing with people with like partial rotator cuff tears. It's like, how are you looking at what makes them get better and out of pain? What is the mechanism? I don't know, and maybe it's just a pure speculation, but where are you at with that?
So this is my favorite subject to talk about. My PhD was literally on the causal mechanisms of the beneficial effect of exercise for rotator cuff related shoulder pain. Causal mechanisms meaning what explains the beneficial effect of exercise. In the shoulder, which is what I love, we don't know. So the tendon doesn't change structurally, but people get better with a loading program. We know that strength doesn't need to change. So force output on a dynamometer or an isokinetic machine doesn't really need to significantly change for somebody to get out of pain or reduce their disability. We know that the scapula doesn't need to change. So posture or motor control doesn't need to change. The only robust mechanism so far that we have for explaining any beneficial effect of exercise for rotator cuff related shoulder pain is a reduction in fear of movement. And so that's fascinating. So maybe it's a psychological thing. Maybe it's all between the ears. Maybe we're improving confidence by moving their arm, and that translates to an improvement in their pain. So I don't want to go down that full psychological pathway. I think there is something biological and biomechanical happening. I think maybe there's something from a biochemistry perspective happening within the tissue that we can't see on a scan. So you'd need to biopsy that tissue, right? And that's a problem because biopsy isn't great. But we do see when we biopsy people with a painful rotator cuff tendon versus a non-painful rotator cuff tendon, the whole inflammatory biochemical environment is totally different. There's much more upregulated inflammatory cells in a painful tendon versus a non-painful tendon. So is exercise changing that biochemical environment somehow? Is it flushing out all of the substance P and the inflammatory chemicals within that tendon and promoting some sort of a healing pathway through that? Now that's an unanswered question, and we're highly involved in researching that at the moment. And Neil Millar is a big proponent of that as well. Maybe we'll have some sort of inhibitory drug that's going to inhibit a lot of these inflammatory mediators, which is going to help people with their rotator cuff tendinopathy. And maybe that's what we need to do instead of exercise. And maybe exercise is just a slow and inefficient way of doing the same thing that a drug will do in the future. But I think exercise is really important because we're trying to train that, like, people come in because they've got a difficulty moving often, right? If you've got a musculoskeletal condition, that manifests as difficulty moving, be it Achilles, be it patella, be it shoulder tendinopathy. And so exercise is just such a natural treatment because it involves movement. It involves doing the thing typically that presents the pain or brings on the pain. So I find it such a powerful intervention to do because straight away you're going to be changing that person's experience with doing that movement. Plus, you get all the beautiful secondary benefits of, yeah, maybe I am changing the mechanical properties of the tendon. Maybe I am slightly increasing collagen deposition in that tendon. Maybe I am reducing blood pressure and having a cardiovascular effect as well. Maybe I am increasing muscle mass because everybody's so chronically undertrained in today's society. So, it's a really good, valuable intervention to do, but maybe down the line it's going to be a pharmacological intervention.
Yeah, I've had similar thoughts where I'm like the playing both sides of the fence, where it's just like I know that the exercise is probably the best thing to do, but what if we could just not do that and something else would make it better? Um, yeah, that's fascinating though. The other one I had was on stiffness. So when it comes to like patellar tendon, well, I'm convinced that there is that research that the tendinopathic Achilles tendon is more compliant, so it strains more for the given stress, and that's not good because you don't want the thing. Maybe it gets injured easier. Maybe there's more chance of a rupture if this thing is just not as stiff. I think the same is happening in the patellar tendon. So like stiffness is kind of a thing you're going after, especially in someone who really uses their Achilles and patellars in like an explosive manner, like a basketball player or a track and field athlete. Stiffness is probably a big part of the rehab. When it comes to the rotator cuff, stiffness, is this even a thing you're ever thinking about or something you're like trying to improve? Is it the same case where it's like if it's a throwing athlete, we want to improve stiffness? If it's just a regular 70-year-old dude that just wants to walk without pain, what's going on with tendon stiffness and the rotator cuff?
I don't know. Um, I have my own hypotheses. I think stiffness is a really noble thing to aim for. I think if you can, because the data is clear. The better your tendon, the stiffer it is, right? No matter what tendon you're investigating, you want a stiff tendon because that causes an efficient transfer of force from muscle to bone. You want that. So I know that in the Achilles and in the patella, you can change Achilles and patella tendon stiffness with a loading protocol. I'm well aware of all that literature and I love it. I have an Achilles tendinopathy right now. And guess what I'm doing? I'm doing interventions to improve the stiffness of my tendon, knowing full well that I don't have to, knowing that I could probably just get a massage and do some crappy little calf stretches and I might get better at the same rate, But why wouldn't I strive to have the best functioning tendon as possible? And for that, I'm doing, a 90% maximal voluntary contraction, 3 on, 3 off, Aaron Patz's type Berlin method protocol. And I'm finding it's really helping me. But I'm not stupid and naive enough to know that there might be some other things that would help me as well. So when we take that to the rotator cuff, we don't really have any studies to show that tendon stiffness increases with a progressive exercise program. We have one study or two studies that show that stiffness does not change after an exercise program of the shoulder. Now, was that exercise program sufficient to stimulate enough tenocytes within the rotator cuff tendon to generate a change in stiffness or mechanical properties? That's a great question, and we're going to have to do better studies on it in the future. It probably wasn't. It certainly wasn't, 90% MVC. It was like 70% MVC. So we don't know. It's an open-ended hypothesis and an open-ended question, and we have to do the work on this. And we've got another 10 to 15 years in front of us before we have any information on it. Now, for me, do I think a change in tendon stiffness is necessary for a reduction in shoulder pain on average for every individual with rotator cuff related shoulder pain? No, I do not. Are there going to be subgroups of people that may benefit from an increase in stiffness? Absolutely. Can we actually change stiffness of the rotator cuff tendon in a predictable and robust way? I don't know, but I think it's something we should test. We've got a bunch of scientists around the world engaged in this research at the moment, so we'll have more data and knowledge in the future. At the moment, I don't think we should be going out to our patients and saying, you have rotator cuff related shoulder pain. We must stiffen this tendon, and we do this via this particular exercise. It's not as simple and as linear as that. It's way more complex when we're talking about pain and functional outcomes. I'm a little bit more sympathetic to it if your only goal is to change tendon stiffness, but that shouldn't be your only goal when you're dealing with pain. You know, that's just one factor that you're dealing with. Yes, strive to create the healthiest tendon that you can, but just be wary that that's not really an evidence-based opinion at the moment for the rotator cuff. It certainly is for the Achilles and the patella.
Yeah. How'd you get your Achilles? How'd that happen?
Running, I'm a 38-year-old man that started running after about a 20-year hiatus of just doing sort of gym-based stuff and surfing. And then when you get older, I don't know, there's like a weird itch that happens that you want to start running again for some reason. Everyone does a marathon in their 30s and 40s, and that happened to me. I also noticed that my VO2 max was really bad. I got like a new Garmin watch, and they're like, your VO2 max is like in the 40s. And I'm like, what the hell? Because I really identify with being a fit person. So I'm like, I got to improve this. So I just started trying to improve that. And then I caught the bug of running, and I've increased my VO2 max by like 10 points over 9 months. So I'm up to like in the mid 50s, which is good. And now I want to break a 5K, a 20-minute 5K, and that's my aim at the moment.
Yeah. Um, it's always a similar story when the lower limb tendons come about. This big
Yeah,
change in load. And then age too. Age definitely doesn't
yeah,
help.
yeah.
Um, all right, man. This has been good. This is a lot to think about. I think for everyone. I hope. I have to bring the parallels of patellar and Achilles because that's the things that I think about all the time. But it just helps my understanding of rotator cuff. Tell everyone where to find you online and things you got going on.
Thanks, mate. Yeah, it's been a good chat. I love talking about Achilles patella, but specifically the rotator cuff because it doesn't get as much love in the world. So thank you for bringing the shoulder on, Jake. Really good. Um, I'm at my website is shoulderphysio.com. Nice and easy. My Instagram is shoulder_physio. I do a bunch of stuff on Instagram. It's fun. I love Instagram. And then, yeah, all my course details are up on my website at shoulderphysio.com. And I got a podcast, the Shoulder Physio podcast. So it's all easy to find. If you type in shoulder physio, I'm saturating the market. I'm everywhere.
Yeah, man. Great. Thanks for coming on.
Cheers, Jake.